Dear students, today we will discuss a very important topic concerning acute viral respiratory infection, acute and chronic bronchitis, and pneumonia in primary care. First, we will start with acute respiratory virus infection. A few words about definition. The definition is self-limiting infection of the respiratory tract manifest by catarrhal inflammation of the respiratory tract and proceeding with fever, runny nose, sneezing, cough, sore throat, disturbances of the general condition of varying severity. Acute respiratory infection diagnosis is based on data from epidemiological history and clinical symptoms. So, according to this definition, I would like to stress that acute respiratory virus infection is self-limiting. What does it mean? It means that mild course disappear, nevertheless, our treatment. And it's very important for prevention of spreading infection is isolation of the patient. So its main cause is viruses, and main clinical manifestation is the lesion of the mucous membrane of upper and lower respiratory tract, mostly upper respiratory tract infection, which symptom of so-called catarrhal inflammation. It's catarrhal inflammation by visible, you can detect red color of the mucous membrane. No symptoms of purulent inflammation, because if we detect purulent inflammation, it means the bacterial infection at the etiology role in this kind of inflammation. I would like to revise your knowledge concerning upper and lower respiratory tract. Upper respiratory tract is nasal cavity, pharynx, larynx, and lower respiratory tract, trachea, bronchus, and lungs. First, its clinical form of acute respiratory virus infection is acute rhinitis, inflammation of mucosa of nasal cavity. Typical symptoms: sneezing, runny nose, difficult nasal breathing, nasal obstruction. So the outflow of mucus of the back of the throat causing a cough. Nasal mucosa is edematous, is often hyperemic, and during acute illness is covered by a mucus discharge. So it's very important how can we distinguish, for example, allergic rhinitis. It's because acute respiratory virus infection often accompanied by fever. Maybe it's low-grade fever, but acute allergic rhinitis, it's chronic process, it's not acute process, and it's a reaction to allergy, and practically never accompanied by fever. And also pharyngitis and lesion of the pharynx. Inflammation of pharyngeal mucosa, you can see reddish no pus, only reddish color of the mucous membrane, and the reaction of the submucous vessels is characterized by there is a feeling of dryness and sickling in the throat and pain when swallowing. That's why if you detect, for example, rhinitis plus symptoms of pharyngitis, it's clinical forms of acute rhinopharyngitis. The main diagnosis, main group, acute respiratory virus infection, and clinical forms, acute nasopharyngitis. Tonsillitis, it may be also bacterial, and viruses, infection of viruses, it's catarrhal inflammation and no pus. If we detect pus, you should suspect bacterial etiology. So local changes in tonsils characterized by intoxication, redness, and swelling of the tonsils, palatal handles, tongue, posterior pharyngeal walls, loose overlay in the gaps. Laryngitis, inflammation of larynx involving the vocal cord and subglottic. The first symptoms is dry barking cough, hoarseness, tracheitis, inflammation in trachea mucosa, symptoms, soreness in the chest and dry cough. By the way, you should often understand what kind of cough, and the main useful classification cough, it's a classification for duration of cough. Cough may be first acute cough, duration cough less than 3 weeks, subacute cough duration more than 3 weeks up to 8 weeks, and chronic cough duration more than 8 weeks. By the way, today we discussed topic concerning chronic bronchitis. Chronic bronchitis is cough duration more than 3 months during 2 consecutive years. We will say it about later. Okay. And also acute cough, it's typically for acute bronchitis. Inflammation in the bronchial and any caliber. And you can see international classification, the disease 10 edition, and this coding of acute laryngitis, tracheitis, and that's why, for example, G01 it's common cold, or acute rhinitis. It's an example of classification and etiology. Most common etiology is influenza viruses, parainfluenza viruses, respiratory syncytial viruses, adenoviruses, and now we are living in the pandemic of coronaviruses. Previously, it's approximately only 5% among all infection maybe belong to coronavirus infection. Now it's significantly highest, and all cases of ARVI, acute respiratory virus infection, we should suspect about coronaviruses, rhinoviruses, and other. The main pathogen acute respiratory virus infection parainfluenza viruses, laryngitis, clinical forms, main syndromes, and nasopharyngitis. Human respiratory syncytial viruses infection, bronchitis, bronchiolitis, adenoviruses, pharyngitis, tonsillitis, bronchitis, by the way, lymphadenopathy, because adenoviruses can traction to lymphoid tissue. That's why we, in the case of vaccines, we use adenoviruses vector to send, for example, S protein of the coronavirus into the immune tissue, lymph nodes. Rhinoviruses, common cold, rhinitis, pharyngitis. Human coronavirus, common cold, nasopharyngitis, bronchitis. But now coronaviruses from their clinical manifestation from the symptoms of common cold up to acute respiratory distress syndrome can lead to death patient due to coronaviruses. But so few words about pandemic of coronavirus infection start with in China in December 2019, and now approximately 500 million cases of coronaviruses, and globally 6.2 million deaths from coronaviruses. It's a very important challenge for medical service, this pandemic. And by the way, in this slide you can see two type of recommendation. In Russia Federation, we treat and diagnose of coronavirus infection according temporary recommendation by Health Ministry of Russia Federation. And in case, for example, this National Institute of Health and recommendation updated, for example, last updated in May 2022. I will say about it later. So the entrance gate of the coronaviruses is epithelium of upper respiratory tract, and target cells should be present receptor for angiotensin converting enzymes. Receptor which help to S protein of coronaviruses invade into the cells. And a lot of this type of receptor in, for example, epithelium of gastrointestinal tract, and also alveolar cells type 2 and other cells. This moment of infection, coronavirus invade into the cells. Epidemiological characteristic incubation period now it's significantly diminished from 4 to 5 days due to last Omicron subtype of coronaviruses. And transmission ways is airborne, air dust, and other. And the main and reliable method of detection of coronaviruses, it's a nucleic acid amplification test with sample collected from upper respiratory tract nasopharyngeal as a mild anterior nasal of oropharyngeal to diagnose acute infection. But in some cases can be use of antigen detection S2, but it's not significant. And more sensitivity and more specificity, it's nucleic acid amplification test. The clinical symptoms of ARVI: increase body temperature, cough, shortness of breath, fatigue, and feeling of congestion in the chest. With COVID-19, it also may be throat, runny nose, decrease of sense of smells, hyposmia of anosmia, and taste dysgeusia. Signs of conjunctivitis, myalgia, confusion of consciousness, headache, hemoptysis, diarrhea, nausea, skin rash, and other. Clinical type of manifestation of COVID-19: acute respiratory virus infection, pneumonia without respiratory failure, pneumonia with acute respiratory failure, acute respiratory distress syndrome, sepsis, sepsis shock, thrombosis, and thromboembolism. COVID-19 classified by severity into the several categories. Mild course. This course can be treated at outpatient condition, and body temperature below 39.5 degrees of Celsius, and symptoms of lesion of upper respiratory tract, and no criteria for moderate and severe course. What about moderate course? Fever above 38.5 degrees Celsius, respiratory rate more than 22 per minute. That's why in case of a mild course, it's less than 22 per minute. Shortness of breath of exertion, pneumonia by CT scan or X-ray investigation, and saturation of oxygen by pulse oximetry less than 95, but more than 93. So it may be 95 or 94. Serum CRP more than 10 milligram per liter. Serum CRP, seroactive proteins. It's a very important biochemical markers for systemic information. That's why if I would like to stress that, namely mild course of COVID-19 infection, we can treat at outpatient setting, outpatient condition. That's why patient should be fever less than 39.5 degrees of Celsius, saturation 95 and more, respiratory rates less than 22 per minute. Severe course and saturation less than Oregon 93, and respiratory rate more than 30, but it may be drop of blood pressure, unstable hemodynamic due to infection, toxic shock, and other other signs. We can detect these signs due to the investigation in inpatient setting. But in the case of primary care, but today we discuss our topic in disinfection in primary care at outpatient condition First, we check respiratory rate if it's more than 30 per minute, and drop of saturation, drop of blood pressure. Such patient should be obviously hospitalized because it's this situation is life-threatening, and it's extremely severe course crucial in case of foreign classification. For example, National Institute of Health, it's a so-called crucial course of COVID-19, septic shock, multi-organ failure, acute respiratory distress syndrome, and other. So, risk group. What patient have high risk of mortality and complication from COVID-19 infection is firstly it's a person more than 65 years of old, pregnancy, woman, comorbidities, including diabetes mellitus, oncology, disease of endocrine and respiratory system. By the way, in this classification, I should insert obesity, because approximately 70% from lethal outcome have got obesity, compared with diabetes mellitus, or only 39%. Okay. So I talked about temporary recommendation health ministry first, but now we are living in case of 15 recommendation from February to 22. Patient, according to first recommendation, it's was contact group, and you can see this isolation for 14 days. Now it's not necessary, and we should, it's this component of temporary recommendation. Now it's not improved of new recommendation. Only patient with suspicion of COVID-19 infection with signs of acute respiratory virus infection, mild course. And this signs of mild course, saturation of oxygen more than 95%, fever less than 38, respiratory rate equal or less than 22. And what should we do? Management maneuver. And first we should make swab from the nasal oropharynx on the day of treatment. By the way, in real clinical practice, all physicians which have special education concerning acute COVID-19 infection should obtain the swab from the nasal pharynx using of express test for COVID-19 infection. Registration of sick list for at least 7 days, isolation at home, and patient which treated in case of outpatient condition have should be have a daily audio monitoring of the condition, but it's very important things, because in some cases infection start as a infection of acute respiratory virus infection of listen by upper respiratory tract, switch to lower respiratory tract, lung and deterioration of the disease's condition, dyspnea, the signs of drop of oxygen saturation should be checked by a physician and medical staff. And patient after recovering, we will say it about criteria of recovering, can be discharged and close the sick list. And if we detect patient with positive COVID-19 test, we should inform patient, and we should send immediate notification of a case of novel coronavirus infection to the territorial bodies of the Federal Service of Surveillance of the Consumer Right Protection, Human Welfare, and notify the head of medical organization about positive test results. The patient should sign the concern about outpatient treatment. If we have patient meet with criteria of mild course, and the patient should strictly follow the regime of self-isolation. And also patients these forms of concern about outpatient treatment and compliance with the self-isolation regime should be signed by patient. And if there are no symptoms of disease, the patient is considered to have recovered. The certificate of incapacity for work in the form of electronic documents is closed, including base of the results of investigation. And medical care for patients with positive test results of COVID-19 can be provided at home, is absent of clinical manifestation of disease of mild disease. Standard case definition of COVID-19 infection, suspicion of case of COVID-19. Patient have signs of acute respiratory virus infection, increased body fever, cough, drive with sputum, shortness of breath, and blood oxygen saturation, and patient likely cause of COVID-19 infection, and to addition of the signs of acute respiratory infection, have got epidemiological data for return from the contact with past 7 days. Previously, it was 15 days of person with COVID-19 infection. So the plus epidemiological data, and patients have got a clinical manifestation of severe pneumonia, present of clinical manifestation combination with characteristic change in lung according to X-ray studies, and confirm a COVID-19 case, positive lab test for presence of RNA of SARS-CoV-2 infection using nucleic acid amplification method by PCR, or antigen using immunochromatographic analysis, regardless of clinical manifestation. And the statistical coding: coronavirus infection caused by COVID-19 viruses identified U 07.2, If no identifiers and identify U07.2 and other, for example, observation, contact screening, coronavirus infection, unspecified. So you should obviously perform if we meet with patient with suspected coronavirus infection. Firstly, but you should firstly should perform assessment of visible mucous membrane, auscultation in the lung, palpation of lymph nodes, examination of abdominal organs with the deterioration of the size of the liver and spleen, perform thermometry, pulse oximetry, assessment of the level of consciousness, measure of heart rate, blood pressure, respiratory rates. And these vital signs should be write down and in primary documentation. It's obvious. But I would like to say that you should contact with patient at previously. You should take on all necessary personal protective equipment, including respirator, disposable glass, goggles, and type 1 anti-plague suits, shoot covers, and other for self-protection. Mild course, but so in a mild course of it's approximately up to 80% from new coronavirus infection, and patient can be treated on outpatient basis. No additional lab tests are required. But if, for example, patient have got some comorbidities, firstly, you should strictly recommend such patient hospitalized. If patient have no concerns to treatment in inpatient condition, you should sign informed concerns about treatment at outpatient setting, and for concerns for self-isolation. And sometimes it's some patient with comorbidity with cardiovascular disease maybe need personally for example, for common blood analysis, for maybe ECG investigation, but it's not for all patients. But most patients, and for new coronavirus infection with mild course, can be treated without additional lab investigation. But pulse oximetry and ECG, for example, in men recommended over 55, women over 65, person of any age with history of cardiovascular disease. By the way, pulse oximetry is instrumental method for all patients. For all patients, it's the quality of medical investigation and medical service. So radiological method is not recommended for patient with mild course, with no symptoms of lung involvement. If patient have a drop of blood pressure, and patient who got those signs of acute respiratory failure, patient should be directed to firstly inpatient condition, and patient should be undergo radiological investigation, chest CT, including chest CT scan. But one lab investigation for all patients, it's detection of RNA SARS-CoV-2 infection by PCR. But in the real clinical practice, it's use of rapid SARS-CoV-2 test, and for PCR for such category of patient, complicated epidemiological analysis, medical workers, patients suspected pulmonary acquired pneumonia for all patients, by the way, and other different groups. Okay. By the way, it's NIHA recommendation for patients who not require hospitalization of supplemental oxygen. It's mild course. And all patients should be offered symptomatic management. For example, if patient have got a fever, patient can use paracetamol, acetaminophen, but patients who are at high risk of progression to severe COVID-19 infection can be treated. Now, according to this recommendation from May 2022, it's combination drugs, ritonavir, boosted nolumapavir, it's Paxlovid, and remdesivir. It's the first line. If this drugs is not available, and patient can treat it at outpatient condition. Firstly, it's monoclonal antibody against S protein SARS-CoV-2 viruses, bebtelovimab, and antivirus drugs, molnupiravir. And by the way, this panel recommendation against the use of dexamethasone and other systemic corticosteroids, it's absent of desaturation. It's not you please not use systemic corticosteroids in case of systemic corticosteroids in case of mild course of infection. Recommendation treatment according temporary recommendation of Russia Health Ministry. This from first to third regime of treatment, including 2 antivirus drugs. First, it's favipiravir up to 10 days, and molnupiravir and umidapiravir, and plus intranasal alpha interferon. In the patient which not vaccinated, in addition, in inhaled corticosteroids, budesonide, DPI 8 100 milligram QAT. And for all patients, it's paracetamol or acetaminophen. Favipiravir, we prescribe a patient to course 10 days. The first days, it's dependent from the weight of patient, 1,600 milligram QAD. And then other days, 600 milligrams QAD if patient weight less than 75 kg. If more, we increase dosage up to first dosage 1,800 milligram QAD, then 800 milligram QAD from 2 to 10 days, from 2nd to 10th days. And molnupiravir is oral prodrugs of beta-D hydroxytidine. It's this drug lead to destroy of amplification of the viruses and viral mutation and lethal mutagenesis. And also these drugs prescribed orally twice up to 5 days. Hospitalization patient with suspected COVID-19 infection and special department for treatment patient with new coronavirus infection with special equipment and special. And the patient who tests positive for COVID-19 must be hospitalized if patient have one or both signs regardless of temperature. Respiratory rate more than 22. Blood oxygen saturation according to pulse oximetry less than 93. A mild course, but patient more age is over 65-year-old, comorbidity, pregnancy, and living together with person with risk group. And also patients who have comorbidity, including chronic disease, heart failure, diabetes mellitus, bronchial asthma, by the way, obesity, congenital heart disease, lung disease, and pregnancy. Okay. So, by the way, I told the sick leave list we give with mild course first for 7 days and then after recovery when patient have no symptoms and fever less than 37 degrees of Celsius, no symptoms of intoxication, and it's criteria for recovered patient in outpatient setting. Inpatient have got previously primary positive PCR test for RNA coronaviruses. You should repeat this test. Patient with negative tests should be cover sick leaves without any additional investigation, including PCR for coronavirus infection. And by the way, if we are talking about sick leaves list for patient with acute respiratory virus infection without COVID-19 infection, for example, in common cold, the sick leaves list up to 5 days. For example, nasopharyngitis, it's 10 days. For example, tracheitis, 10 days, bronchitis 15 days. Okay, now we are talking about acute bronchitis. It's according international classification of the disease G12. Acute bronchitis is short-term inflammation of the bronchus, all size. The most common symptoms is a cough. Other symptoms include coughing up mucus, wheezing, shortness of breath, fever, and chest discomfort. The infection may last from a few to 10 days. The cough may persist for several weeks afterwards, with the total duration of symptoms usually around 3 weeks. So I would like to repeat once more. Acute bronchitis is typically acute cough. If patient have got previously some chronic respiratory disease, it's acute bronchitis. Nevertheless, that may be virus infection lead to affection reason of upper and lower respiratory tract. By the way, bronchitis and bronchitis is lower respiratory tract. That's why, but if a patient have chronic bronchitis, if patients have got a COPD, chronic obstructive pulmonary disease, bronchial asthma, it's a virus-inducible exacerbation of the main disease. That's why we should check and ask patient about previous cough. If patient cough is not acute, it's not, you have no right to make the diagnosis of acute bronchitis. An acute respiratory tract infections that maybe lasts up to 3 weeks is which cough, with or without phlegm, is a prominent feature, and alveolar inflammation is not present. That's why it's obviously in case of acute bronchitis, you should exclude pneumonia. Common up to 5% of adult self-report an episode each of acute bronchitis. So in more than 90% of cases, the cause is a virus infection. This virus may be spread through the air when people cough or by direct contact. A risk factor includes exposure to tobacco smoke, dust, and other air pollution. By the way, it's very difficult to if patient have tobacco smoke. It's exposure. You should firstly suspect chronic bronchitis for smoking people, and practically it's impossible. This smoking patient have no smoking, no coffee. But a small number of cases are due to higher level of air pollution of bacteria such as mycoplasma pneumonia, Bordetella pertussis. And the type of inflammation: simple, mucopurulent, purulent, and fibrinosis, membranosis. But in my clinical practice, I met with simple, mucopurulent, and purulent bronchitis, acute bronchitis. According to predominant localization of the lesion: proximal, large bronchial, distal, and bronchial tubes, acute bronchitis, and acute bronchiolitis. And according to presence of obstruction, not obstructive bronchitis, and obstructive bronchitis. Main symptoms: cough, and in most cases is start with dry cough, then after 2 or 3 days of onset of illness, cough becomes productive. Start to expectorate a small amount of mucus, And symptoms of acute bronchitis: dyspnea in severe case, auscultation, vesicular breathing with prolonged exhalation in case of the signs of obstruction, diffuse dry rales, signs of acute respiratory virus infection, also maybe accompanying urinary redness of mucous membrane of the nasopharynx, other symptoms, and plus symptoms of intoxication, fever, headache, malaise. And diagnosis, the signs of acute generalized inflammation of the bronchial tree, and diagnosis base of that it's acute process. It's not exacerbation of chronic process of respiratory tract. And also diagnosis base for excluding of pneumonia. The diagnosis of acute bronchitis in outpatient practice necessarily involve the differential diagnosis with other disease, for which cough is one of the leading symptoms. The criteria for diagnosis are signs acute generalized inflammation of the bronchial tree, usually infection etiology, and which symptoms consolidation of the lung parenchyma is not detected. Diagnosis of acute bronchitis in ambulatory practice necessarily involve the differential diagnosis, which other disease for which cough is, pardon? The first steps to diagnosis, you need to decide which disease is likely related to acute cough. Imaged with infection lesion of the lower respiratory tract or non-infection disorders such as asthma, heart failure, pulmonary embolism, and others. By the way, acute cough in maybe, for example, heart failure due to myocardial infarction, and pulmonary embolism may be also accompanied by acute cough and pneumonia. That's why in very useful classification, acute cough may be with radiological signs and without radiological signs, but acute cough in case of acute bronchitis, it's acute cough without any radiological signs. That's why we should strictly recommended patient undergo this investigation for exclude pneumonia. And second step, decide we should exclude pneumonia by using radiology method of investigation. Differential diagnosis: acute exacerbation of chronic bronchitis, pneumonia, tuberculosis, pulmonary thromboembolism. Main goal of treatment: elimination of symptoms of respiratory tract embolism as soon as possible, decrease severity of symptoms of intoxication, and prevention of complication. It's antiviral drugs. It's possible, but it's not obviously. It's immunotherapy, arbidol. In case of influenza, we should prescribe oseltamivir for 3 to 5 days. Arbidol we prescribe 200 milligrams 4 times per day. For oseltamivir, 75 milligrams 2 times per day. If patients have got a sputum, we should use mucolytic drugs, including ambroxol, acetylcysteine, carbocysteine, bromhexine. In case of what about antibiotic therapy? Antibiotic therapy is not indicated for uncomplicated And then now opinion. There are three opinions about antibiotics. First, we should use. Second, we should not use antibiotic, and delayed prescription of antibiotic and delayed antibiotic therapy. What does it mean? Because in case of onset of infection, patients have got maybe mucopurulent sputum, but it's not means this signs of bacterial infection. In 1 or 2 days, this in case of virus infection, this mucopurulent sputum can be transferred to mucous sputum. It's not this means, because I repeat once more, virus infection is self-limited infection. If, for example, patient have a purulent sputum up to 5 days, no positive clinical dynamics you should exclude pneumonia. You can prescribe, you can delay antibiotic therapy, including macrolide, azithromycin, clarithromycin, but maybe first choice, because now patient with new coronavirus infection use of a lot of macrolide and macrolides, and the resistance to macrolides now in the world significantly increased. But choice number one is amoxicillin plus clavulanic acid to prevent the destroy amoxicillin by beta-lactamase, and these drugs are useful for treatment patient with chronic bronchitis as a delayed antibiotic therapy. What kind of treatment we should not use in case of acute bronchitis? It's but previously, maybe 2 years ago, we prescribed fenspirit as anti-inflammatory effect with prevent bronchoconstriction. This drug, but now due to significant side effect, you should not prescribe fenspirit, please. But in case of dry cough, we should very carefully can prescribe, for example, central antitussive drugs, including butamirat, for example, Sinicot, Claudin, Claven, dextromethorphan, for example, Tussin plus, and other drugs, antitussive drugs. In case of dry cough, if, for example, if a patient suffering from dry cough and you prescribe mucolytic drugs, it's not correct. But cyclics, period of temporary disability for common for acute bronchitis, from 10 to 2 weeks. Chronic bronchitis, chronic inflammatory disease, the bronchi characterized by morphological reorganization of mucous membrane of the bronchus. Chronic cough with expectoration for at least 3 months of the years for more than 2 consecutive years. Epidemiology, the prevalence from 10 to 20% in Russia Federation, and the forms and classification according international classification of disease. etiology factor, cigarette smoking, pollutants, infection, gastroesophageal reflux disease, and clinical forms: simple, non-obstructive, mucopurulence, bronchitis, purulent, and infection, which including Haemophilus influenza, Streptococcus pneumonia, Moraxella infection play an active role due to exacerbation of chronic bronchitis. So, anatomic alteration of the lung, including chronic inflammatory process and swelling of the peripheral airways, excessive mucus production, accumulation of the sputum, partial mucus plugging, hyperinflation of air trapping, smooth muscle constriction, and bronchial bronchospasm. But it's more typically for only due to exacerbation. But in case of chronic bronchitis, in most of cases, in period of remission, mostly it's only chronic inflammation, excessive mucus production, and practically never you can detect the signs of obstruction. That's why if you detect signs of obstruction, firstly we should think about chronic obstruction pulmonary disease. And so if you met with a case of chronic bronchitis, firstly we should verify the diagnosis, identify the stage of disease, and definition of the main it's chronic or acute process. Now, what does it mean, verify of diagnosis? Firstly, we should exclude other. For example, it may be a patient which who have a tobacco smoke with history, maybe have got a lung cancer. We should exclude lung cancer, and other disease which accompanied by chronic cough, including cardiovascular disease. And the patient should undergo physical examination, complete blood count, C-reactive protein, general analysis of the sputum, spirograph investigation, chest X-ray to pneumonia, and exclude, for example, lung cancer, CT scan of the chest if you suspect presence of bronchitis, and you should suspect maybe lung tumor in TASA. Goal of treatment: elimination of symptom, acute illness, decrease in the rate of disease progression, and prevention of repeated exacerbation, improving the quality of the life. So, patient and family education, very important, and stop smoking, behavior management, and avoidance of infection. In this case, immunization against, for example, pneumococcus, immunization against influenza, immunization against coronavirus, and respiratory care treatment protocols. And in case of exacerbation, we can prescribe macrolides, amoxicillin plus clavulanic acids or respiratory quinolones. It's thought of fourth generation oral cephalosporins. Second generation, and the cyclics if a patient simple chronic bronchitis due to exacerbation up to 2 weeks, and mucopurulent chronic bronchitis up to 80 days. Temporary incapacity. So in rare exacerbation, clinical examination not more than 3 times a year, inspection therapeutics 2 times per year, and lab investigations, parametry, including spirometry and the ECG. When a frequent estimation, you should see patient at out your polyclinics 3 times a year. Community-acquired pneumonia. We talked about it several times. I would like to stress community-acquired pneumonia. It's a one type of pneumonia can be treated in outpatient setting. And it's pneumonia happen in outpatient condition or 4 weeks after discharge from the hospital on first 48 hours after hospitalization. And pneumonia accompanied by symptoms of infection of lower respiratory tracts, including fever, cough, sputum production, including purulent sputum, chest pain, shortness of breath, and radiological signs of fresh focal infiltrative change in the lung in the absence of the diagnostic alternatives. So among 2 leading causes of death in the world, and, acute lower respiratory tract infection, obtains third place. Most community-acquired pneumonia are the most frequent disease in human and in the one of the leading cause of death from the infection of disease. The main 3 route of infection passing it into the lung tissue. It's inhalation, including inhalation, aspiration, including microaspiration, and hematogenous. It's more typically for viruses because it's bilateral infiltrates of the lung. And microbiology, it's first place obtained pneumococcus, then intracellular microorganisms, including chlamydia, mycoplasma, legionella, and also Haemophilus influenza. And practically it's not 3–5% gram-negative bacteria. Diagnosis: gold standard acute onset, fever, cough, acute cough, X-ray detectable infiltration of the lung. If affection pleural, visceral pleural, it may be accompanied by pleural pain and dyspnea. A patient should undergo investigation, including complete blood count, its leukocytosis, and shift to the left, X-ray, and first day, and in dynamics. In leukocytosis more than 10 giga per liter, shift to the left, toxic granularity of the neutrophils indicated high likelihood of bacterial infection. Leukopenia below 4 giga per liter, leukocytosis about 25, unfavorable prognosis signs for bacterial infection, but you should know that leukopenia, it may be typically for virus infection. For example, for SARS-CoV-2 pneumonia. Typically, microbiological tests are not recommended by primary healthcare level. but you should pay attention to so-called modifier factor that increase risk of infection with specific pathogens, penicillin-resistant and drug-resistant pneumococcus age more than 65 years old. The history of using beta-lactams therapy within the past 3 months, alcoholism, for example, it's for aspiration pneumonia by gram-negative microbes, immunosuppressive illness, for example, corticosteroids, immunosuppressor condition, for example, HIV viruses, and it's a higher risk of pneumocystis pneumonia. Multiple medical comorbidities, exposure to a child in a daycare center, residents in nursing homes, underlying cardiopulmonary disease, and other. For pseudomonas aeruginosa, it's structural lung disease, bronchitis, corticosteroid therapy, broad spectrum antibiotic therapy more than 7 days, and malnutrition. And in a primary case, very important to distinguish severe course of pneumonia from not severe course. It's this scale, group 65, help you to detect severe course, and your medical decision concerning the site of treatment this patient. But for first contact with patient, it's more useful CRB 65, including confusion and blood, urine nitrogen, respiratory rate, blood pressure, systolic blood pressure, diastolic age. See, for example, if patient have got some kinds of confusion, for example, agitation of depression, of stupor, it's 1 point. If patient have got a respiratory rate, it's also 1 point, more than 30 per minute. If patient have got a systolic drop of blood pressure less than 19, diastolic blood pressure less than 16, and age more than 65, so it's 1 point. That's why a patient can be treated at outpatient condition if CURP looking forward 0, but maybe some exclusion for age 1 point. But by the way, it's pneumonia. It's a less threatening condition for the patient. That's why you should strictly recommend for patient with pneumonia for hospitalization. But if patient have got for according to CURP or CRB 0, he can treat patient at outpatient condition. Other things, it's hospitalization. For example, if patient have got a 4-5 point in intensive care unit, for example, 2 point, it's therapeutics or pulmonary department. It's antibiotic therapy. Patient with pneumonia can be divided into 2 groups for treatment and outpatient condition. The non-severe course of community-acquired pneumonia, CRB 0, age up to 60 years without comorbidities. Such patient can be used first choice of drugs, amoxicillin orally or macrolide. Its alternative protocols is respiratory fluoroquinolones. If patient second category, patient 60 years of old or older, with concomitant disease with indication for antibiotic therapy. The first choice of drugs is amoxicillin plus chloronic acid, anxiety defenders amoxicillin, and respiratory fluoroquinolones. This recommendation, you can find its recommendation Russian Respiratory Society. Much better if you use amoxicillin plus chloronic acids when amoxicillin 875 milligrams and clavulanic acid 125 QID. In this slide, you can see the macrolide, azithromycin, josamisin, and respiratory quinolones, moxifloxacin, levofloxacin. Criteria for starting effectiveness of therapy: if after 2 or 3 days, body temperature reduce less than 37.5 degrees Celsius, reduction of intoxication, a reduction of manifestation of respiratory insufficiency, and but I would like to stress in case of outpatient setting, you should not treat a patient with acute respiratory failure. Such patients should be obviously hospitalized. A mild course for duration of antibiotic therapy from 7 to 10 days, but then we should stop therapy, and we should analyze the response for stopping of therapy. If in case of normalized condition and no increased fever after stop of therapy, we should make conclusions that we destroy causative microorganisms which lead to pneumonia. And after 3 weeks, we should cover of sick list and stop of temporary disability of patient. So, but duration of therapy may be different from 2 to 7 days in outpatient and inpatient, some more. Indication for hospitalization: signs of severe illness, ineffectiveness of starting antibiotic therapy. That's why if you know effect after 48 hours of the start of therapy, such patient should be hospitalized, obviously. Inability to adequate care and performance of all medical prescription in outpatient condition, and relative indication: age over the 60 years, severe concomitant disease, COPD, bronchitis, and heart failure, pregnancy, and other. And prevention: pneumonia, including vaccination against pneumococcus and against coronaviruses and against influenza. The time lapse is over. If you have any question, you can ask me in chat or during practical classes. Thank you for your attention and goodbye.